You're tuned in for another deep dive, and today we're really focusing specifically on labial adhesions in young girls.
Yep, a really important topic for anyone revising pediatrics.
Exactly. We've gone through the standard medical review notes.
And the idea is to pull out the key stuff for you, make it high yield, easy to remember.
Right. So let's start right at the beginning, the definition. What exactly are labial adhesions?
Okay, so simply put, it's a fusion. The labia minora, the inner vaginal lips,
They stick together.
they fuse, yeah, typically right in the midline. And you usually see this in girls maybe aged about 3 months up to 3 years.
3 months to 3 years. Okay.
And what's really important is that it often sorts itself out spontaneously,
Mhm.
especially around puberty.
Ah, okay. So it often resolves later, and crucially, it's not an imperforate hymen, right?
Absolutely not. That's different, where the hymen completely blocks the opening from birth. This is the labia minora fusing after birth.
Got it. Fusion of inner lips, young girls, often gets better on its own, different from imperforate hymen. Okay. What about the why? The etiology.
Well, the honest answer, the exact cause isn't completely nailed down.
But what's the thinking?
The main idea revolves around things like irritation or inflammation, maybe hormonal influences playing a role on that really delicate vulvar tissue in young children.
Okay. Irritation, inflammation, hormones. Makes sense. So that leads to risk factors. Who's more likely to get this?
Right. There are a few clear things. Young age, as we said, that's number one.
Okay.
Poor hygiene can sometimes be a factor. Also, a history of UTIs, urinary tract infections, and any kind of local irritation, maybe even minor trauma down there. And sometimes you might find an underlying skin condition is involved too.
So quite a few things. Is there a way to maybe remember those?
You could try something like, young, poor hygiene leads to irritation and trauma, sometimes skin issues. Does that help?
Young, poor hygiene, irritation, trauma, skin issues. Yeah, that works. Okay. Pathophysiology then. How does that irritation actually cause the fusion?
It's pretty logical, actually. You get that irritation or inflammation happening on the surfaces of the labia minora. And because they're inflamed, they can become sticky, essentially. The surfaces touch, they adhere.
They stick together.
Exactly. And over time, these adhesions form this bridge, which can then partially or even completely close off the vaginal opening.
So irritation makes them sticky, they fuse, can cause a blockage.
Yeah.
Okay. Now, if you see this or suspect it, what else needs to be on the radar? The differentials.
Yeah, super important. You need to think. Could it be something else? Labial fusion caused by lichen sclerosis is a key one.
Okay, lichen sclerosis.
Also, congenital anomalies, something structurally different from birth. Urethral prolapse can sometimes look a bit confusing.
Yeah.
Maybe a vaginal foreign body.
Right.
Or, other things that might cause the vagina to seem narrowed or stenosed.
Yeah.
Possibly other structural or skin issues presenting similarly.
Good checklist. How common is this actually? Epidemiology.
It's hard to get precise prevalence figures. But we know it's considered common in girls before puberty. And importantly, it's generally benign.
Common and usually nothing serious.
Right.
How does it actually show up? Clinical presentation?
Well, you might physically see that partial or complete closure of the vaginal opening. That's the main sign.
Visible fusion.
Yeah. Parents might report symptoms too, maybe urinary frequency or urgency. Sometimes recurrent UTIs are the first clue.
Ah, the UTIs again.
Exactly. Or maybe the child complains of some vulvar discomfort. On examination, you'll typically see these thin, sort of semi-translucent adhesions covering the opening.
Semi-translucent, okay.
And sometimes you might even notice urine getting trapped, pooling behind the adhesion after she pees. But yeah, most cases do have some sign or symptom.
Visible fusion, urinary issues, discomfort, maybe that urine pooling. Got it. How do we confirm the diagnosis? Investigations.
Usually it's straightforward. The physical examination is key. Just seeing the adhesions is normally enough for the diagnosis.
So just look carefully.
Pretty much. It's rare to need more, but if things are unclear or you suspect something else like lichen sclerosis, maybe a biopsy or other test might be done. But that's not routine.
Okay, examination first. Management then. How do we treat it?
The first-line approach, for most cases, is conservative, especially if it's not causing any bother. Good hygiene advice is crucial.
Just watch and wait with good hygiene.
Often, yes.
Yeah.
But if there are problems, like those recurrent UTIs we mentioned, then treatment might be needed.
Like what?
Topical estrogen cream is often the next step. applied directly to the adhesion.
Oestrogen cream, and if that doesn't work,
Then you might consider surgical intervention, basically separating the adhesions. But that's usually reserved for when the cream doesn't work or if there are significant ongoing problems.
start simple, cream if needed, surgery only if really necessary. What's the general outlook? Prognosis.
Generally really good. Excellent, actually.
Mm.
Remember, spontaneous resolution is common, especially around puberty.
Right. It often goes away by itself.
Or it responds well to conservative management like the cream. Complications are quite rare.
That's reassuring. But what complications could happen even if they're uncommon?
Well, theoretically, if the blockage is severe, you could get urinary retention.
Difficulty peeing.
Yeah. Recurrent UTIs are a potential complication if not managed. And, sometimes there can be psychological distress for the child or the family because of the appearance or the symptoms.
Okay, retention, UTIs, distress.
Mhm.
Uncommon, but possible?
Great.
Okay.
So let's just quickly summarize. Labial adhesions, common, usually benign, seen in young girls.
Often resolves on its own or with simple measures like hygiene or estrogen cream.
Key is recognizing it, distinguishing it from other things, and knowing the management steps.
Exactly.
Okay, final thought to leave you with.
Yeah.
Considering how common this is, but often goes unnoticed or resolves spontaneously, what other seemingly minor childhood conditions might have surprising underlying mechanisms or associations we should be thinking about?
Food for thought. Definitely. Thanks for that really clear run through. And for everyone listening, if you want more top-notch MSRA revision resources, don't forget to check out pastomsra.com.
And also freemsra.com for, free resources.
Perfect. Thanks again.